This is the MDedge Psychcast, the weekly podcast for and by psychiatrists. I'm MDedge editor Gina Henderson, filling in for Nick Andrews. Since today is Christmas, we thought we'd highlight one of our favorite interviews from 2019 by Dr. Lorenzo Norris. In this episode, Dr. Norris spoke by phone with Dr. Caroline Bonham and Dr. Avi Kriechman of the University of New Mexico about their work in preventing youth suicide and providing rural mental health care. Dr. Bonham and Dr. Kriechman focus on enhancing resilience among young patients and their families by connecting them with resources such as churches, community organizations, and food banks. The goal is to leverage the strengths of rural communities. We'll be right back.
Welcome to the MDedge Psychcast. My name is Dr. Lorenzo Norris, Editor-in-Chief of MDedge Psychiatry. Today we are very privileged to be joined by Dr. Bonham and Dr. Kriechman, who are going to be speaking with us today on the topic of looking at how we can enhance resilience in rural communities. So I would like to thank Dr. Bonham and Dr. Kriechman for being part of today's MDedge Psychcast. Dr. Bonham, could you please talk to us a bit about what we're seeing right now in rural communities in terms of the increase in the rates of suicidality?
So there's been a long-standing disparity in terms of risks of suicide when you look at urban communities versus rural communities. Nationally, the rate of deaths by suicide has been increasing over the last decade across the United States, both in rural and urban communities. And so when you look at those long-standing disparities in rural communities, you're seeing an increase in those rates as well.
All right. Dr. Kriechman, in regards to these increasing rates of suicide, do you have any perspective in regards to what we're seeing in youth in rural communities, particularly in terms of the suicide rates?
I think that in addition to what Dr. Bonham was talking about, there's a paucity of providers in general in mental health, but especially in youth and in families. And some of that is also the challenges that families and schools and those agencies and organizations that support youth and their families have suffered in recent years. There's also, of course, the impact of structural poverty, and there's the impact of the opioid epidemic.
Okay. All right. So, Dr. Bonham, all right, so I'm thinking about this in terms of what we're seeing in terms of suicide in rural communities. Now, I trained in New York City. I trained in an urban area. I'm currently a psychiatrist in GW, DC urban community. What, if anything, in terms of practice, do psychiatrists need to think about when they're thinking about suicide in rural communities in terms of their practice? Maybe they need to change something. Maybe they don't need to change anything at all. But do you have any insights in terms of how psychiatric practice may change or transform when you're working with rural communities?
So one of the big barriers is stigma when we think about accessing care. So in a large urban environment, when somebody can be fairly anonymous in going to a large hospital or a large system and asking for treatment, it's much more vulnerable to ask for help in a small community where you may go to school, or you may have kids at the same school as the provider that you're going to be asking for help. And so really being conscious of how vulnerable it is to ask for help, and being aware that the stigma around having mental health conditions and sometimes what that means in a small community can be very different in a small community versus a large urban setting.
Adding to that, what we have looked at very much is when we're looking at enhancing safety and promoting resilience, communities have wonderful resources that aren't really tapped into by a traditional kind of individually based, focused medical care. And so looking at a contextual, culturally competent model is really important to unearth hidden resources, and that also goes for psychiatrists and other behavioral health providers feeling comfortable with the community of support, care committees in churches, teachers' aides, physicians' assistants, peer support workers, community health workers, looking at that broad spectrum of care. One of the things that's really heartening is recent studies of populations are that most communities have a significant majority of people who identify knowing people who are at risk for suicide. And more importantly, over 90% are very much wanting to help if they're given the resources to do so.
Okay. Now, I'm just trying to make sure I heard that and everything that you all are saying. So on one hand, we do have to take into context that these rural communities, smaller communities, there can be certain barriers, including stigma, and also, if you will, issues of confidentiality. On the other hand, though, and now work with me on this, if you access these communities or if you work with these communities, there could actually be opportunity to leverage things in a way in which we wouldn't maybe be able to do in an urban area because of just the size and intimacy of the community if they can work with each other and build resilience and support through their own local, if you will, just kind of connections and networking. So to me, when I think about it, the rural community, it can, just like any community, it can have advantages and disadvantages to it. And as a psychiatrist, if I was practicing in a rural community, I need to really just understand that and how I can best work with that particular population.
Yeah, that's excellent. I can give you some easy examples. I know some community resources where they operate food banks out of the mental health center. Mm-hmm. They help with supported housing and employment. Mm-hmm. They connect to spiritual organizations. They help support aftercare programs in schools. Mm-hmm. So they think outside of the box, and we can help facilitate those natural resources if we pay attention to them. Okay. Now, so we know that suicide rates are increasing in rural communities. We know that we're establishing, just like any community, that rural communities have different characteristics or different strengths that mental health professionals, I should say, just not psychiatrists for all those in the audience, they have different characteristics which we have to think about and that we can leverage in terms of working with the community. Now, the next thing that I would, in terms of what we're getting at here, in terms of resilience and building resilience in rural communities, are there any specific, Dr. Bonham touched on this idea of stigma, but are there any specific things, again, with that idea of practices or things that can be done in terms of building resilience? Maybe we should even start with building resilience in individuals in rural communities and then move to the communities themselves. But that idea of what would it look like to build resilience? Well, I think one of the things that we found really helpful is having a strength, competency, skill-based kind of way of assessing people. Mm-hmm. And looking at engaging them in a collaborative, transparent process of care. Mm-hmm. So some of the models, for instance, in our youth suicide prevention program are collaborative models where the youth directs the service. Mm-hmm. They identify a peer or a family support who is their mentor as opposed to a professional. All the documentation is totally transparent to them. They're mm-hmm. involved every step of the way, and there's a needs assessment based on not deficits, but strengths that they already have that we want to build upon. Okay. And the other thing I wanted to throw in that Dr. Bonham and I have talked a lot about is the literature is very supportive of the idea that if the people who do not have a problem, whether it's with suicide or a physical ailment or a severe mental illness, if they are taught to reach out and destigmatize mm-hmm. and facilitate the treatment, then the outcomes are much better. So again, it's not being individually focused and focused on pathology and deficit. It's being community-focused in a collaborative, synergistic, strength-based way.
Okay. Can you elaborate on that with just an example? Because I think that's such a very important point in terms of a member of the community reaching out and again with this collaborative, strength-based perspective. Can you give the audience just maybe a practical example of like what that would actually look like?
So, for example, one of the risk factors that we know is particularly high in rural communities is death by firearms.
Okay.
And so, for example, there have been examples of mental health professionals working with gun store owners who might be the place where somebody might be going to purchase a weapon.
Mm-hmm.
And so actually kind of working with the store owners, too, about what are the risk factors for suicide, how they might, if that person has a concern about somebody coming in to purchase a firearm, what would they do? What kind of questions would they ask? How would they encourage them to seek help? Where would they refer them to? And again, in a small community, that's actually a feasible intervention, and that referral pathway is a little bit easier in a smaller community than in a large system.
Yeah, and following up with what Dr. Bonham was saying, there's a lot of police departments that are really wonderful about providing education about the safe storage of firearms. Sometimes if there's a concern about a family member, they'll even store them for that person with no legal charges. It'll be very positive about ensuring safety in the household as opposed to punishing people for access to firearms. So, which is very important about talking about firearm safety as opposed to firearm control.
I think that is a really, really great and interesting example. I was born and raised in Cleveland, Ohio, but I actually spent the vast majority of my summers in Alabama, Montgomery, Alabama, Birmingham, Alabama, as an example. And when you spoke about firearms and a gun store owner, that actually resonated because as I thought right now, if I was to do some form of a gun safety intervention in D.C., where would I start? Is the local like Target or I don't know if I don't think Target sells guns, but Walmart or something of that nature. Would that store, if you will, manager be able to listen to me in the same way to somebody who owns their own gun shop or firearms store, and for that matter, maybe a community leader or someone recognized in a small town? And I think that actually offers, now that I think about it or say it out loud, it offers a very rich opportunity to make a very impactful intervention in a way that would be, I would approach it very differently if I was doing this work in D.C. Or the urban areas here as compared to what may be possible, that one-on-one individual really building a relationship with key people in the community and affecting incredibly impactful change. So I think that I did not think about that, but that's very interesting.
And just another example is when we're looking at access to lethal means as far as medications, a lot of parents don't realize that the appearance of a medication can be confusing to kids, so they'll think it's candy, or it's attractive in a certain kind of way. And so it's really important. I think what we're saying is that education is really important in a non-judgmental, non-critical way, because people are really wanting to help.
Okay. All right. Now, we touched on a bit, we gave us an example here in regards to the community and a very practical example of reaching out and working with community, if you will, members I really like that term, strength-based, if you will, assessment. Now, another thing that I think is important to bring up is this idea of the assessment and the assessment being truly contextualized and individual. And Dr. Bonham, I was wondering if you could comment a little bit further on that as it relates to rural communities.
And again, actually, with that strengths-based theme, I think it's actually always helpful to start with a strength-based assessment, too. And so really understanding what does that person's support network look like, what are their spiritual and religious beliefs, what are their protective factors, and starting there as a base, and then really kind of being very careful about what the risk factors are for that person in that moment. But starting with those protective factors and those strengths actually helps to start to work on a safety plan, and then also really helps for that individual who is at risk at that time and coming forward with some vulnerability to start to think about how to reach out to their family, to their friends, to some of the community members.
And there's actually evidence-based rating forms. So from the DBT school, there's the Reasons for Living inventory. And so, and a lot of it is sort of like indirect suggestion that if you start with the Reasons for Living inventory and then go into risk factors, it is a wonderful way of connecting to somebody's strengths and resiliencies first and getting them to think about that as being a critical factor. Most people, when they're doing an assessment, it's looking at a history of difficulty, challenge, and failure and deficit, and almost no interest in attending to the opposite.
Okay. Now, given the work that you all have done, all right, in rural communities, and if you were trying to intervene, let's say with an individual, given some of the things that you've talked about in terms of strength-based assessment, building resilience, overcoming stigma, what would be would you approach the individual first, or would you go through a family member, or would it just be whichever type of way works best, so to speak, or what's available to you?
And I think it does depend. And so it really depends on how that person is presenting. Are they presenting themselves? Is the family or the community presenting the concerns? So I think it really, in some ways it is whatever is the best way to build a relationship with that person, keep that person safe, and then again to really start to work on safety planning with that person.
Yeah, I think we very much view that the same way. I think that the other part of that is that our division and our center is very much focused on community interventions. So we do a lot of outreach to a wide network of community support to give them this background, this training, this information, so they know how to access all these different factors, and so that when somebody comes, no matter how they come into the attention of caregivers, that they have this community support that's built in. We also look at a lot of initiatives here like mental health first aid and natural helpers and community gatekeepers, all sorts of models where we're alerting lay professionals, interested community members in how to identify people at risk and ensure that those people that they care for and care about will find a way to access the system and often facilitate that sort of warm handoff into the system. So the individual approach and the community approach can be synergistic with each other and go hand in hand.
Okay. I noticed, obviously, given your research, you all feel like you use a number of evidence-based tools in regards to whether it's safety planning. I believe that you all also will frequently make use of CAMs or evidence-based interventions for suicide. The question I have is actually two questions. How receptive are rural communities to the use of these evidence-based procedures? And then second, do you have to make any modifications or tweaks to these standard procedures to better account for the current setting that you're in terms of rural communities?
Yes and yes.
Okay, great.
Yes, and I think people are very receptive. We do a lot of training both with community members and providers on models like CBT for suicide prevention. We also do a lot of work on kind of making sure that the models are a good cultural fit, too. So, for example, one of our partnerships is with some of the tribal communities in New Mexico.
Okay.
So, again, we do a lot of training on evidence-based models, but then also really rooting it in that cultural context and the local values, too. So it's for many of our tribal partners, things like language preservation, traditional spirituality, and involvement of tribal leadership are really key components, too. So we look at the model, and then how does it fit within the local culture?
I think one of the basic things that we look at is practice-based evidence as opposed to evidence-based practice, and that also that when we're teaching these models, I look very much at common factors so that of which there are a lot, and that we're not rigidly trying to implement an evidence-based practice, but we're using those as templates for discovering the best fit for that particular individual. So basically presenting that individual a menu of options that they can select from.
Okay. Now, my next question, you all have devoted a great deal of time in regards to community-level interventions in rural communities that form this synergy between the community as well as the individual in using, if you will, evidence-based modalities. My question for both of you would be, what, as you've done your research or as you've worked with these communities, what has generally surprised you about their resilience? What has made you go, wow, I wasn't expecting that in all the work that you've done?
I think we're sort of pausing because there's so much to talk about.
yeah, I know. So it's a tough question.
Yeah, I think just speaking from my own sense, it was a change really in my entire career to be opened up to a contextual, transparent, strength-based model. And what I find is that when I present that as a white male psychiatrist, people are almost like in disbelief that I would be talking in a non-hierarchical, non-authoritarian, culturally competent, collaborative, transparent kind of way, and they really welcomed that. And the fact that most of the models that we talk about are that the person is the expert on the person, not us, and that we spend a lot of time listening and developing rapport and trying to find out how they will guide us in what they need, as opposed to sort of having a rigidly structured set of procedures and a way of being in which we view them as lacking something that we can fill them up with. So it's that, again, that the Vygotsky model of scaffolding as opposed to that we're their foundation.
Yes. I would agree with that. Not agree with that. I mean, it's your experience, but when you said that, what it made me think about is even my own training. And I love what you said in terms of non-judgmental, non-hierarchical, culturally competent. And when you said that, what it made me think about is when we're able to approach and collaborate with our patients in that manner, we're able to see strengths that we weren't even aware of. And a lot of times, instead of us thinking we're teaching them, they're really teaching us. And we're simply just there to guide them in terms of their own, if you will, their journey and what it is that they can do to improve, if you will, or optimize their own health. So, again, I want to thank you both for speaking with us about giving us some key points or ideas regarding to, if you will, building resilience in rural communities. And I would like to just close the conversation now and give you all the floor. If there is one key point that you want the audience to take away from working with rural communities and building resilience, I want you to tell us what it is.
Again, it's really that encouragement to step outside of the office and find partnerships with local community leaders and to start that conversation. It's just so rewarding when there's that sort of sigh of relief that somebody who doesn't normally talk about something like suicide gets a chance to talk about it, and then to see that creativity of the local problem-solving initiatives that will emerge.
And I wanted to promote my colleague here. I think that it's also important to have a community support within your professional sphere, and what Dr. Bonham and a lot of her colleagues have built here in this division of center are people who are engaged with the community, looking for resources and strengths, not just in the people that we try to provide for, but in each other, and view each other as sort of a community of support. And I think that's really important in doing this work.
All right, Dr. Bonham, Dr. Kriechman, I want to thank you so very much for speaking with us today on the MDedge Psychcast. You really emphasized the role of approaching building resilience through strength-based assessments, and that rural communities, just like any other community, respond to an authentic, collaborative approach. So thank you so very much for speaking with us, and hopefully we'll get an opportunity to get an update from you guys in the future and hear what more of the outstanding work that you're doing.
Next Wednesday, you'll hear another one of our most popular episodes with a brand new installment by Dr. Renee Kohansky. Until then, happy holidays.